Welcome to this explainer. Today, we're diving straight into the critical clinical pathways and nursing care requirements for high-risk newborns. You know, when a newborn enters the world, that transition from the womb to the outside environment is arguably the most physiologically demanding event they'll ever face. And for a high-risk newborn, that transition is literally fraught with danger. So we're going to explore the precise medical complications these incredibly fragile patients face and the highly specialized nursing care it takes to keep them alive. Let's get right into it. We'll be mapping our journey today directly to a comprehensive nursing curriculum. Think of it like a roadmap. It systematically outlines the exact medical complications, from respiratory distress all the way to septicemia, and the practical care standards that neonatal nurses absolutely have to master. Following this curriculum gives us a real behind-the-scenes look at the rigorous, high-stakes environment of neonatal intensive care. So our clinical pathway today covers 5 key areas. 1, the high-risk newborn. 2, asphyxia and resuscitation. 3, respiratory distress syndrome. 4, metabolic and systemic threats. And finally, 5, essential nursing care. Okay, Section 1, the high-risk newborn vulnerabilities at birth. Now, it's really important to understand that not all high-risk babies face the exact same battles. For instance, preterm infants, babies born way too early, they battle profound physiological immaturity. We're talking massive risks like infant respiratory distress syndrome, frequent apnea spells where they just stop breathing, and even dangerous bleeding in the brain known as intraventricular hemorrhage. But then, on the flip side, you have small-for-gestational-age, or SGA infants. These babies might actually be full-term, but their growth was restricted in the womb. They face completely different primary threats. We're looking at things like meconium aspiration during a really stressful delivery, and severe hypoglycemia because, well, they simply lack the necessary glycogen stores to keep their blood sugar stable. Moving on to Section 2, asphyxia and resuscitation, the delivery room crisis. Imagine the delivery room. If a baby suffers from severe birth asphyxia, meaning they basically fail to establish adequate breathing and circulation right at birth, it can rapidly lead to a devastating condition called hypoxic ischemic encephalopathy, or HIE. This is a severe neurological injury caused by a kind of dual threat. You've got hypoxia, which is a lack of oxygen in the blood, combined with ischemia, which is a lack of actual blood flow to the brain and vital organs. Preventing this, it requires immediate, zero-hesitation intervention. When literally every single second counts, the absolute most effective neonatal resuscitation relies on a highly structured, rapid-fire sequence of steps. First up, warm the baby to maintain a normal temperature, because hypothermia can be deadly. Second, reposition the airway and clear out any secretions so air can actually flow. Third, aggressively dry the infant to prevent heat loss. And fourth, stimulate breathing. I know, it sounds simple, right? But flawlessly executing these initial steps in the chaos of a high-stress delivery room is an absolutely critical nursing skill. Now, to evaluate how well the baby is actually responding to that resuscitation, medical professionals everywhere universally rely on the APGR scoring table at exactly 1 minute and 5 minutes after birth. The care team scores the baby's appearance, pulse, grimace, activity, and respiratory effort, assigning a 0, 1, or 2 for each category. If that score comes back low, well, that dictates that life-saving resuscitation has to continue immediately. This brings us to Section 3, Respiratory Distress Syndrome, the breathing battle. Respiratory distress syndrome, or RDS, is honestly one of the most common and dangerous conditions in premature infants, and it's primarily caused by a deficiency of something called surfactant. So what is that? Surfactant is this crucial surface-active material produced deep down in the lungs. Its main job is to reduce surface tension and stop the tiny air sacs, the alveoli, from completely collapsing every single time the baby exhales. Without enough of it, every single breath becomes an exhausting physical struggle for the newborn. Because of this structural lung deficiency, nurses have to be hypervigilant. They're looking out for early visual and auditory clues of RDS. We're talking about tachypnea, which is breathing insanely fast, over 60 breaths per minute. They're listening closely for expiratory grunting, as the baby instinctively tries to keep their own lungs open. They watch for nasal flaring and sternal or intercostal retractions, which is literally where the skin sucks in around the baby's ribs with every breath. If these signs pop up, the baby will quickly spiral into severe hypoxia if breathing support and often artificial surfactant therapy isn't rapidly provided. But it's also incredibly important to differentiate RDS from another condition known as transient tachypnea of the newborn, or TTN. While they might look kind of similar at first glance, TTN is generally a milder condition. It's basically where the newborn is simply struggling to clear residual fluid from their lungs. So it's a delay in fluid clearance, which is completely distinct from the fundamental structural lack of surfactant that we see in RDS. All right, let's look at Section 4, Metabolic and Systemic Threats, the hidden dangers. Beyond the lungs, septicemia, which is a massive systemic infection, is a terrifying risk. Whether it's stemming from maternal transmission, unclean delivery environments, or even the prolonged use of IV lines in the NICU, premature infants are essentially sitting targets. They have vastly underdeveloped immune systems, which leaves them highly susceptible to incredibly dangerous bacteria, like E. coli and Group B streptococcus. You know what makes sepsis so dangerous in newborns? It's how completely deceptive it is. Because their immune systems are so immature, sepsis rarely presents with your classic high fever. Instead, nurses must catch these incredibly subtle, hidden symptoms. We're looking at a baby who suddenly refuses to feed or has temperature instability, which actually often means they get unusually cold, not hot. Or maybe they present with skin mottling and lethargy. Catching these nonspecific signs before the infection fully overwhelms the infant's organs, that is a true testament to the watchful eye of a neonatal nurse. Furthermore, we have severe metabolic crashes to worry about. Hypoglycemia, or low blood sugar, is a constant threat. This is especially true for infants of diabetic mothers who might overproduce insulin, or those small for gestational age babies we talked about earlier who just have completely depleted energy stores. An infant's rapidly developing brain relies almost entirely on a steady, uninterrupted supply of glucose. If those levels drop too low, the infant can suffer from lethargy, apnea, and eventually life-altering seizures. Finally, let's wrap up with Section 5, Essential Nursing Care, the life-saving routine. Managing all these different crises requires a core management routine that forms the literal safety net keeping the fragile newborn alive. This involves maintaining a thermoneutral environment, usually through a specialized incubator, so the baby doesn't waste their precious calories just trying to stay warm. It requires continuous, round-the-clock monitoring of their heart and lungs, meticulously recording every single drop of fluid to balance delicate electrolytes, and above all, preventing infections through strict, uncompromising aseptic techniques. And then, of course, there is medication administration. Because a premature infant's liver and kidneys are incredibly immature, the way they metabolize drugs is vastly different from an older child. Precisely administering medications, whether that's orally, intravenously, or through instillation, while strictly following exact dosing protocols, well, it's one of the most critical, high-stakes practical skills a neonatal nurse performs every single shift. There is literally zero margin for error here. When you really consider the razor-thin margin of safety in the NICU and the overwhelming physiological hurdles these fragile patients face right from their very first breath, it just leaves us with a profound respect for the specialized professionals involved. Their rigorous, minute-by-minute dedication doesn't just manage a temporary crisis, it actively protects the developing brain and organs. So, knowing all these invisible, complex battles, how do you think that precise, specialized nursing care in those first few critical days ultimately shapes the lifelong trajectory of that child?